So it is, well, where did that quick month go? Here it is, the DCC work group's report to talk about what our progress has been since our last meeting in July. So again, we're trying our hardest to do this differently so that we have different results. And I know that each group has been working hard at that. And that's really what it comes down to. We can do anything, but we can't do everything. And so spreading the work out, spreading the efforts out is so important. So I don't know who all is here. I see this is the ones that signed up. Now the ones that I have the orange marks by are people that are on committees. The green are the leader of that group, and the purple is the mentor for that group. I'm not going to go through all these names, but there's a purpose that I have here. Melissa, look at those names. There's a reason why, because Melissa's group needs some help. We'll go back to that. So thanks everybody that's here. Again, we have our leaders, our participants, and those of you that we might want to recruit. And there's a specific thing that's going on. So here's the way the groups worked out. We have the implant maintenance, biofilm management. Melissa Braca is leading that with Joe Grasmick. Remove the provider language, the Patty's. Actually, Patty Korecki with a Y. Is Patty Korecki here yet? Patty, are you here yet? Because it depends on, I may have to change the order that we go in. We have Tasha with Kathy Forbes. Susan Cotton with me, and then Jamie Collins with Linda Jorgensen. Jamie Collins' child, one of her kids, got into a final contest, and she was finalist in some kind of a, I don't know, I think it was showing cows or something like that. They do live in the country. And so she's not here tonight. In the chat box, I need somebody that's going to help watch the chat box for me. Anybody want to volunteer?
I'll watch it. This is Linda.
Thanks, Linda. Thanks, Linda. I appreciate it because, again, we're all multitasking, but that was a little hard for me to watch while I'm leading. Now, I think everybody should be aware of this, but let me, again, just review. The website is in the middle of a transition, and I will keep announcing when things are new. At this point, we have in our insiders section, and again, contact available only to the insiders. In there, we have, this is where the meetings are. This is where I'm posting everything. So if you're on a committee or a work group and you haven't been able to get on a call, this is where they're being posted, okay? You can make comments in there or whatever. I also, this meeting that we're doing tonight, when I say DCC for all members, this was the last meeting that we had 6 weeks ago. That's posted in there. Also, on our other parts of this, let me go and show you in the masterminds, just to, again, to demonstrate what's going on. This is the mastermind that we just did recently, and what's great about this is Lindsay Hill, who wasn't able to be here tonight, does work through, oh, I'm not signed in. Wait a second, let me sign in. What happens is she goes in and she does a quiz. So even if you couldn't attend that particular mastermind, you can go in here and take a 5-question quiz and still get the continuing education credits. Those are done through February of last year. So there's lots of ways. And so if you have people or friends that need CE, it's a great way to tell them a little bit more about what goes on. Also, the calendar under the events here is the best place. If you can't remember the next meeting is going to be, that's posted on here. Now, Sunday's on the right, so it makes it look a little goofy. So right away, I'm going to let you know that our next mastermind is on Wednesday, the 11th of September. And our next consortium, that's one of these meetings, is on Sunday, the 29th of September. Now, so again, that's all there for your use. Patty Korecki, I think you just saw you sign in, and Patty, your group has been doing a great job. And so what I did is I basically put your slides in that you gave me, And if you want to kind of review with everybody what's going on and where the progress of your group is. So Patty, you want to take it away? You can tell me when to change the slides.
Okay, basically what we did is everybody went through the book and found these items that were provider language specific, and so that's just you can go to the next slide. This is just a submission of what they are. Basically, I just took this off. The next slide is off the ADHA site of what, where in the United States the advanced procedures are allowed. So you can go to the next one, which is basically, again, this is where the reimbursement off the ADH site is allowed. It seemed to be that the consensus for our group is that it's preventing people that are providers from being reimbursed at the level at which they should be. And
can we go back, Patty? Can you talk to us, explain, because again, you're now well versed in this, but a lot of people are not. Can you go over what these things are and what we're trying to accomplish with, or discussing, or we're trying to accomplish with this process?
Sure. Basically, the group that we are in was tasked to go through the CDC book and I'm having a real hard time thinking these days, sorry. And basically pick out all the language that was specific to dentists. Because basically our goal is to remove the provider language that is limiting providers, no matter if they're clinician, hygienists or advanced therapists, dental therapists, whatnot. So this is basically areas where we found language that will be limiting for the advancement of providers based on the legislation of the state dental practice acts. Because many states have allowed other people than dentists to provide treatment. And so because the carriers use these policies to pay, we think that the language of just signifying a dentist or general practitioner is too limiting in order to be reimbursed at the level at which they should be reimbursed.
Great. And now here's one of the things too, Linda Jorgensen, the language that we say is that we want the codes to be what? Provider neutral, isn't it?
Provider neutral. Let me just give a quick example that might clarify this whole thing and make it simple. There's no such thing as a prophy code, a prophylaxis code for a dental hygienist compared to a dentist. Anybody who provides a prophylaxis can submit a claim and get paid for it. Huh? Hello? Oh, okay.
Hello, did somebody say something?
All right. No, it might have been a mistake. Anyway, so there are a few locations, a few places in the code manual where it says that the procedure, or it implies that the procedure is provided by a dentist. And what that implies.
It doesn't imply, it says specifically. That's what we're talking about, the language that says specifically.
Right, but then what the CMC said last year was, oh, well, the statutes always trump the code, but that's not always true. Well, in fact, we're not asking to trump anything. What we're saying is, if it says that the procedure in the code, it says that the procedure is provided by a dentist, then an insurance, and it's not a manipulation. I'm looking at that word manipulation. It's just they're looking at, oh, here's the code manual. It says the procedure is provided by a dentist. The person submitting the claim is not a dentist, therefore we're not going to cover it because it says in the code manual that it's provided by a dentist. And so we want all of that. There's no need to have any identify any provider at all. That has to be neutral. Whoever is allowed to do that procedure by law and then submit a claim to an insurance company should have the same consideration as any other provider. So, I mean, we have to make this argument again in front of that committee. And the point is, we have many providers out there doing procedures, and especially now with the advent of dental therapy, they're doing examinations, they're doing dental procedures, they're submitting claims to Medicaid and to regular insurance, and even, just I think, well, anyway, and they need to be reimbursed based on the fact that they did that procedure. So,
John Camisi here. May I ask a question?
I'm sorry?
Hi, John Camisi here. I'd like to ask a question if I can, please. So how does this enable, again, if a therapist or an advanced hygienist or another team member is doing these therapies, are they not necessarily under the auspices of a supervising dentist in some capacity or another? Is there not a dentist who is involved in some capacity with these therapists and these advanced hygienists in most of the states?
Well, there's really only one state that we have good data, and that's Minnesota. And yes, they are working under collaborative management agreements.
So therefore, if that's the case,
Mm-hmm.
then if they're working under the collaborative hygiene or advanced therapy circumstances, why is there a need to neutralize the language? I don't seem to understand this, and I'm just looking for some clarity, please.
Well, this is
Kathy Forbes, can you take this from the Colorado point of view?
Yeah, under Colorado, we don't need a dentist most direct access hygienists are expected to have a relationship with the dentist, but they don't have to. So our state does not require that there be anything that a dentist does. Delta Dental of Colorado, like the definition of a 40 perio maintenance, said it has to be the word dentist is in the definition. And so essentially, hygienists who are direct access practices who perform a perio maintenance and submit, there is no dentist, but Delta Dental of Colorado recognizes that and they pay them anyway. But there are other larger carriers like MetLife and Cigna and some of those that will limit the benefits to hygienists because they're not under the auspices of a dentist. And we know there's at least over 80 direct access practices in the state of Colorado, because Delta told me they do. They have at least 80. So that's where it gets to be challenging.
Mm-hmm. So in other words, this is attempting to give equity to everybody, you're indicating, is that right?
Yeah, medicine does not, in any of their procedure codes, there's nothing in their manual that says it's a ANRP, it's a PA, it's a physician, there's no reference to any certain professional or license before they can do a procedure. They say, hey, if it's allowed in your state, that's the procedure code. There's no mention in any of the medical codes. So we're just trying to bring the dental codes into the 21st century and say we want to provide a neutral language, just like medicine.
Okay.
And another point of it is there's only specific codes where that language is there. So it's like, why are some specifically limited to dentists and others are not?
Turn off the air.
What?
That was somebody who was talking to somebody else, I think.
Okay.
Patty, if you could go down to slide 11.
I don't have them numbered that way, Patty.
Oh, I'm sorry. It's all the way down. Keep going. Sorry.
Keep going? Okay.
Yes.
Here?
Nope. Keep going.
Nope.
Keep going. Okay. Here, Christy Jo Fogarty is, I believe, online tonight, and she is
I am.
yes. Hello.
Hey. Hi, it's Karen.
She is part of our group that she is a practicing advanced RDA. What is your title, Joe?
You know what, why don't we have Christy, Joe, why don't you just go ahead and explain what you're doing and how this applies to you?
Sure. So so I'm an advanced dental therapist. I'm also a licensed dental hygienist. And what we're finding is that we have to bill under our collaborating dentist because private practice insurances, most of them are not credentialing us, and they are not allowing us to do direct billing, despite the fact that, yes, I work under a dentist. Yes, I work in collaboration, but I'm a direct access provider. And quite frankly, I can see I work for a nonprofit children's organization, so I see a lot of peds. Almost everyone I see is, well, they're all under the age of 26, but the vast majority of what I see are probably under the age of 10. And I can begin and complete their treatment. And I'm basically their primary dental care. And so certainly you want that type of a provider to be able to do direct billing, and you want that language neutral. And as more and more states bring on dental therapy, they're going to create different versions in each state. It's going to be just like dental hygiene, where the practice acts are going to look very, very different. And of course, you want your CDT codes to reflect the fact that, just like with medicine, you want that neutrality, because we don't know where this is going to go, and we don't know where it's going to end up, and we don't know what states are going to choose. And we certainly want to make sure that that code is not an obstacle at some point to access to care. Where you have a state that says, boy, much like Colorado, we prefer you have a relationship with the dentist, but we don't necessarily think that 100% has to happen. But that provider is never able to take off in that state because of the limitations within the CDT code. And yes, state statute may trump it, but insurance companies, that's a lot of statutes for them to wade through. What they'd really rather do is just look at a code, know that the provider is licensed to do it in their state, and move forward.
Yeah.
Interesting.
John,
Okay,
can you argue for why the language needs to be there?
well, I'm not sure if I can argue one way or the other. I'm just trying to get clarity because
No, but you're a dentist, and that's why I asked you, because if you can see a reason perhaps that we're missing, that I think it's important for us to understand that. That's why I'm asking.
Well, again, my take on this is the way I'm looking at it, or at least the way I'm hearing it being presented. It seems to be fragmenting the profession rather than bringing everybody together to work in the team aspect. Certainly, I agree that compensation should be equitable to everybody that's involved. But my fear, and again, now as an educator in a university teaching new dental students, I worry for them as they get out and they start to try to create a practice. How are they going to collaborate with the therapist, with the advanced hygienist, and everybody else if they're not even needed any longer? So I think
But is that really what a code should be doing?
I don't know. Again, I'm not wise enough to really understand that. I'm just trying to put clarity in my brain. I'm very glad that I'm not a young practitioner any longer, because if I were to get out of school and I were to set up an office and next door I have another person who's not a dentist doing procedures that I've been trained to do, how does that enable me to run my business, to pay my loans, to pay? So again, I think that we're in a very interesting time frame in which we have the need for an equitable way for everybody in the team to be recognized and compensated. But at the same time, I can see how some dentists out there think this is very militant. Not to be disrespectful or argumentative. I can see it from both perspectives. And I think that's why you have me on your advisory board, because I give an honest and fair and equitable opinion on things. And I'm concerned that the way that this is being presented, or would be presented, if it isn't showing how it becomes part of the team, you're going to get resistance in every facet of what you're doing. So please, everybody that you're working on this, please try to remember that you're trying to keep the profession of dentistry as organized and together as possible, because there's too many entities out there trying to rip it apart.
And I don't
At the same time, what we're seeing is that having something that's only delineated to a certain person within the entire team is doing that more than if it is a provider neutral code. Because again, if there was consistency that would identify all codes, well, somebody can do this and somebody can do that, but there's only a few of them here. It's the inconsistency within the book that we have concerns with. I'm looking for it. Linda, Kathy, where do we add that last year? Remember when we tried to get that through? I think that might help clarify things.
Under 0150.
What is it?
The paragraph for 0150. So let me get.
No, it wasn't 0150. Remember we did it with the 4910, I thought, last year.
Let me grab that manual. Hang on a minute.
Hello?
I just want to say, if it's also about this dividing the team and that sort of thing, there's no problem with when it's provider neutral in the other codes. It's just in these codes where we're finding a reference to dentist. It means that that's now going to be insurance companies they can and they do use that as a limitation or an obstacle, as Christy Joe said, to reimbursement. Now, if
and ultimately the vast majority of dental therapists, and I'm sure even the hygienists in Colorado and California, do have relationships with dentists, and I think quite often work for them despite the fact that they can do that. And the reality is, if insurance companies decide that they want to stick more with language, which is their prerogative to do, and could frankly make it a nightmare for any dental practice for billing if they decided to hire some of these practitioners. I mean, this could be a big problem for dentists in the future as well. And one of the things that always jumps out at me when I'm looking at this list is the teledentistry exam. The teledentistry exams in my practice in Minneapolis, the vast majority of them are done by dental therapists. They are not done by the dentists that we collaborate with, because frankly their time is more valuable than ours. And so they delegate those teledentistry exams to, so everyone's working at the top of their license. That makes our practice more productive, and that's true in private practice as well. So ultimately, this is something that's going to help streamline all billing, which is going to be an advantageous thing for all dentists and all practitioners and everyone in the dental field. I don't see a negative of taking that, making that language neutral. I see that only as a huge advantage for dentists in the future, so that they don't maybe have to stop and do their time to do their teledentistry exams, that they can delegate that to their dental therapist.
Patty, it was a code we presented on. We wanted to change the opening paragraph under diagnostic codes.
That was last year, though, I thought.
Yeah, you asked what we did last.
Yeah.
We did it. We tried to do it a different way this year to try and make it. It was, and I thought it was the 4910 though. Again, I'm sorry. Watching you guys.
I'm sorry. I'm not as prepared.
Patty,
one of the things I'd like to say to Dr. Kamisi is that in no way do we want to do anything that fragments the team, and I do not believe making the procedure code book just procedures has nothing to do with team members is going to fragment. I think hygienists and even dental therapists want that relationship with the dentist, and they will build it, whether by statute or like in Colorado where it's not real required, they do it anyway. We just want the procedure codes just to be that procedure codes, regardless of who does it. There are procedures out there that we just want to delineate. So.
Okay, and I can understand and respect that. I'm just trying to make sure that I'm clear on the direction that you're trying to pursue, and I want to make sure that it's clear. If it can be made clear to me, you have at least a small possibility with some of the more hard liners of trying to make it clearer to them. And
John, this is an example. This is an example. I have it up on the screen. Sorry, I apologize, everybody, for scrolling like that, making you nauseous, but I knew we did it. This is what we submitted on Ontario maintenance this year. And we tried to get it in this way. Instead of it saying, determine the clinical evaluation of the dentist, it's by the dental professional in accordance with the State Practice Act. That's what we're trying to do, is not change State Practice Acts, not legislate with codes, rather make it specific to who really can do it, which is according to the State Practice Act. Does that clarify it at all?
Yeah, and I think this is what I remember being contributory to this language.
I think you were
discussing it last year. And again, this language and this methodology can be very clearly understood and could be clearly embraced by everybody in the profession. And if you go in that manner on the codes that you're trying to change to dental professional, then I think that you'll be with that line, dental professional, in accordance with the State Practice Act. I think you have a much more significant opportunity to make opportunities to improve the overall coding.
And Dr. Kamisi, on Roman numeral 4 in the CDT book, they even say in the beginning, and other individuals may report any listed codes as long as they are delivering procedures and services within the scope of their state law. So we kept thinking when we presented this last year, well, they already said this. We're just, making the actual definition and descriptor match what they've already said in page Roman numeral 4. I mean,
Right.
it's interesting how they make that in the beginning, but then they don't want to say that or amend it in the rest of the book.
Again, it's a very, again, to be very, very understanding of everybody involved. They are concerned, they're fearful of losing whatever control, and they have been in control for decades. And so this becomes a more interesting and challenging circumstance. But I believe that now listening to what you're all saying helps me understand the directionality. So I think if you go in that situation with that whole thing in compliance with the Dental Practice Act by the dental professionals, that makes the most sense to this crazy man here. And I think it might actually make sense to the rest of them as they begin to become aware. As they become more aware of the directionality that needs to be equitably for everybody in the profession. So again, just continue to try to appease the powers that be and enable them to actually get their arms around this, just like you enabled me to get my arms around. So thank you kindly.
Thank you.
Thank you.
Patty?
Patty, going back to Patty as the chair as a leader of this work group, you have the list of, has there been any contact yet from your group to any of these other associations? I see we have some targeting going on here. Has any of that happened?
No, the people that I talked to from the that had gone to Under One Roof said that there were not any connections at this point for any of the partners so far. We discussed more, where the direction needs to be as far as who is this going to be helping in the future, and why we, more specifically, if you scroll down to another slide, you'll see what we want to accomplish is to request editorial changes from the limiting provider to more of a neutral language.
Yeah.
And provide cross-coding ability, which, everyone wants to eventually move to the medical dental coding, and then to remove roadblocks to achieve and maintain optimal oral health. Basically just by having the whole team focus on oral health as opposed to who exactly does what, as long as they're licensed to do so.
Patty, if I could just interject real quick regarding developing coalitions. One of the challenges I ran into last year, not starting to reach out before September, is that many organizations, their boards make policy on what they're going to do, and the boards will have already met and weren't going to meet for a couple more months, and yet by November 1st this has to all be in. So all the subgroups need to be thinking about making those relationships sooner rather than later, so you're not caught behind the 8 ball of, well, our board's not going to meet, so we can't even talk about it.
And that's really a good important point that I will be making again several times. Our timeline, I really tried to work this timeline differently, and that's why I tried to give the group here some dates and some landmarks, because quite literally, guys, we have to have our submissions done for full approval of all the insiders in 1 month. That's our timeline. And the idea of building the coalitions is not so much that we have the language already done, but what we've experienced is we thought it would be a much better strategy to come in with some ideas, but talk to the other people in coalitions who could add language. And then when you develop language together, you're more likely to come up with something that is satisfying to a number of parties. And that's where, again, we may be just, it's a learning curve, and we might be able to do that again better for the next year. Because as an example, even within, since an awful lot of us here are hygienists, let's just talk about ADHA. ADHA cannot support any of our submissions or even sign on with us unless it's already in our policy. That's how this stuff works. Policy is, again, our House of Delegates votes on policy. That policy is then administered by the leadership, but this is another way it all works together. And so even if we came up with something now, unless ADHA already has it in policy, they can't support it. Well, that's true of all of these groups. If you look at these groups are all from the associations, and those associations can't countermand or do something that their group has not already voted on. Kathy and I heard that, what was it, 3 years ago, Kathy, when we were talking to AAP about changing something. Actually, it was about changing the language of the dentist in one of the 4355 code, I think it is. But whatever it is, she says, I can't go against what my association has directed me to do. That's why this building coalitions in advance is so important. So anyway, so where are you at with your next part that you're going to do, Patty?
Basically, we were at this point, you know, is basically working on the codes, but you know, the next time we meet, we'll probably have to go more towards trying to build, you know, coalitions with some of the groups.
Well, you actually have your codes done too, so we'll go back to that. So Melissa, I know Melissa's been challenged. Melissa, you there, girlfriend?
I'm here, Patty. How's everybody?
Yeah. So we have all these nice names on here. Unfortunately, they've had either difficulty getting together or whatever. So Melissa, just go ahead and you and Jill talk about where you're at and what we might need to do and how maybe other people we're going to need to bring in other people to work on this.
Right. And you had made some connections that you shared with me after UOR, and I had reached out to them, and unfortunately, I've had the same response. I know everybody's busy. I know everybody's got a lot going on, but I'm just having a really hard time coordinating everybody's schedule and getting to meet together. Unfortunately, we've only held 2 meetings where the attendance was only 3 people for each meeting. So what Jill and I have done as liaison and the group manager is that we're just trying to do some work. Siobhan has been very great doing some work with us as well. What Jill and I worked on the other day was, Chris Potts did come to a meeting as well, and she was instrumental on talking about establishing that letter that you were just discussing with getting coalitions together. So those are some of the professional affiliations that we're looking for to get on our side. Jill drafted a great letter that I'm going to send out to the team this week so that they can disseminate it to any of their contacts that they know, so we could start getting some coalitions on board to help support us. The other thing, we really haven't touched so much on biofilm yet, but we're hoping that we can get some support on that with AOSH. There's a lot of science there supporting the need for biofilm management coding and how important that's going to be to all of our practices. So that's where we're moving with that as far as professional affiliations go. What we did last year was we really tried to hit the gamut of every single type of implant patient that we all experience in private practice with the group. And anybody that is working in implant dentistry knows that it's multifactorial and not every implant patient is the same. And as a matter of fact, there probably are no 2 that are exactly the same. And we tried to really take that approach when we created these codings for last year, and unfortunately we know how that turned out. They all got declined. So we're taking this approach differently this year, and we're really trying to make it as simple as possible. And instead of giving them so many codes, we're going to do an edentulous code. And then the other idea Jill and I were kind of discussing back and forth on Friday was with biofilm, when we approach that, having a biofilm management for natural teeth and having biofilm management for patient with implants. So that we can maybe
explain to the group how biofilm management is different than a prophy or the things that we've been doing already.
Well, with biofilm management, I practice with the EMS Airflow Master Piezon. So what I'm doing is I'm removing all biofilm on my patient before I even pick up an ultrasonic power scaler or a hand scaler, so that I can properly eliminate biofilm in a safe manner with my implant patients. I'm actually not touching the implant. It's a supragingival approach, but it's done with powders that can eliminate bacteria more fully than I ever could with any other instrument or with a hand scaler. And especially with our erythritol powder, it's able to combat against some very pathogenic bacteria. And that has such a huge impact on patients' oral health, but also their systemic health. And it also will help with making sure that we're, like I said, safely treating our implant patients. So we're not doing anything that's going to cause any iatrogenic harm to our implant cases.
So we're talking about a procedure that, I mean, we had air polishing before, but this is not in the same category. This is not stain removal. It's not any of those standard things that most of us think of, I mean, that have been traditionally thought of. And one of the things about the coding committee, they specifically in 2012, with the formation of this version of the committee, they voted to meet on an annual basis. And part of that is to accommodate the changes that we have in technology and the way we can treat. This certainly, to me, sounds like something that would come under that type of thinking. Have I got that correct?
Absolutely. I couldn't agree more with you, Patty. And there's more changes coming down the pike and improvement of that for us soon. Technology is constantly growing and getting better. What was the other thing? I just went brain dead for a second. I'm sorry. I was going to say something else before you said that.
While you're thinking about that, we have a volunteer. Val said that she would be on participate in the group. And Val, didn't you lead the group 2 years ago?
Yeah, we did. Yeah.
Yeah. Okay. Good. So you got a great volunteer there. Anybody else want to volunteer to help with this group? Because this is an area that we really felt last year that we would have success with. And to be honest, again, to reiterate, for those who haven't heard us say this before, is what really appeared to happen at the committee is something went down with AAP and NADP. They had submitted, I don't know, Kathy, what was it, 20, 30 codes together?
Yep, exactly.
And we thought, boy, you get NADP and you get AAP together, you got power players. And those all went down in a crash and burn. Don't know the politics behind it, they did. But once theirs went down, we saw ours go down.
Yep.
And so it really, I don't think it was our submissions, but there's something about the whole perio area this year that committee didn't want to do a darn thing about. So, don't always take it that just because something didn't go through, especially when we put something through the first time. I mean, there's many people on this call that have done work legislatively in their states, and it takes more than one time. More than one time. For some people, they never heard it before. This is something new. It's too new. Or again, let's go back to, if they don't have any policy or any information that they've talked to their associations about, they sometimes can't support it for that reason.
Well, Patty, I also... Go ahead.
What? Go ahead, Kathy.
I also have a personal opinion that there were 147 codes. And I know when I printed it out, because I'm kind of anal that way, the manual was 2 inches thick. And if I were a voting member, I could read that for 6 months and not get it all down and digesting. And I really believe there were particularly new people on that CMC that probably just thumbed through it. And when they saw the other people going one way, I think it was like lemmings. I really do think that they just, I don't understand it. Gee whiz, there's other people that understand it. Let's just vote it down. And I personally believe that probably played into it to some extent.
You're asking
And
about
I think that's why your
politics,
approach,
Patty,
hold on one
about
second, John. I
politics?
think that's why your approach, Melissa, of having it simpler and
Yep.
having less is better. Go
Yep.
ahead, John.
Okay.
Yeah, the politics right now is that the periodontal, most of the specialty groups are having a really tough time. They are actually starting to, quote unquote, gang up on the general practitioner because they're feeling the market share starting to hit them. So I think that any changes coming in from any other arena, they're going to stop or squash because the periodontists are feeling it, the orthodontists are feeling it, everybody, and then endodontists are starting to actually do things that are squashing general dentistry, or at least bad-mouthing general dentists, not being as trained as they are. So if they're already bashing their colleagues in their own profession as far as dentistry goes, in the dentist aspect, what are they going to do with the team members as they start to present and find that their market share continues to drop? We're in a very precarious state right now, and the specialties are being hardest hit because the generalists are taking on doing more and more specialty work. And as the hygienists and the advanced hygienists and the dental therapists continue to move into those territories as well, you're going to see market share crisis occur. So that's the politics that you're involved in right now. And that's why if you're going to do this, you got to do it in a smart and appropriate way that will not have them feel and get their defenses up. Right now, everybody's shields are up.
Well, my approach to this and my team's approach to this is that, you know, we're trying to do the best for these patients, and the dental implant patient population, in my opinion, in the most part, when it comes to maintenance, they're very neglected patients because we as a profession, and I'm including general dentists in this statement, we don't know how to treat them when it comes to maintenance.
Yes.
No question. I agree 100%. I stumble upon that on a regular basis because if we don't clean the biofilm off of the tooth that we're trying to restore, our composites fail faster than the speeding bullet.
Mm-hmm.
Right, and now we're taking, you know, when their teeth have failed, and now we're just, their solution to the problem is let's throw titanium in their heads and then scratch our heads why that fails, because we're not actually going to the source of the problem to begin with. So anything that I am approaching and my team is approaching is really patient-centered care. You know, we're trying, that's where my passion lies, is that I want to do everything in my power and do it right by the patient. I'm sure that many of the professionals on this call feel the same way. So that's where, you know, we're trying to head this too. So I hear you with politics, and I understand that politics exists, but I get very frustrated when we talk that talk, because at the end of the day, it's about the patients. It's not about the politics. We should all be doing what's best for our patients. And
no disagreement on this end.
No disagreement. I don't think we have any disagreement on this committee. Siobhan, can I call on you as the other? I mean, you guys with your Implants Unlimited, you're doing some amazing work. Do you have anything, other comments to make, Siobhan?
Just pertaining to implant dentistry, it is a team approach, and that's one issue that we're having in implant dentistry. That's one reason why peri-implant disease is on the rise. That's one reason why we are failing our patients with dental implants, is because we are not taking a team approach. You do have general practitioners who are performing the work that should be considered specialty, and that's just not considered in general dentistry. That's in dental hygiene as well. We all take an oath that we have to advance care and be able to, like the consensus, right? Patient-centered care, but we're not really practicing that way. And that's too bad that we can't separate our personal opinion or feelings from the problem here. And then just going back to what we were talking about earlier, you know, dental hygienists are trained to do oral examinations. We are trained to do diagnostics. We are practitioners that have extensive training in these procedures, and so that's why the language needs to be neutral. We are not trying to say we don't need dentists. We are just trying to be recognized for our roles in patient-centered care. But the collaboration part is important, and we've had many conversations about the importance of education, and so I guess we just need to continue to educate each other and just honor the role that we are all here to serve in dentistry. But when it comes to dental implants, that's one major. I mean, 90% of dental implant complications are due to clinical error and the lack of knowledge and skill of the clinician.
Terrific. Okay, so we've got more people on that committee, that work group. So, keep going. And again, if you need more help, then just reach out. Please, we're here to help. Susan, are you ready with our oral cancer group? Susan Cotton?
Yes, I'm here. I'm ready.
Okay.
I have to unmute myself. So we have, gosh, my group, they're amazing, this oral cancer group. And thank you, Patty, for being our mentor. We've really made some strides. We came up with our talking points for our potential partners. And here are some of our potential partners that we've, here's a list of all that we're going to contact right here that Patty has up. We do already have some potential partners we've contacted and they've agreed to work with us. And one is the Oral Cancer Foundation, Dr. Andy Nemechek, an MD, ENT, head and neck oncology surgeon here in Denver, who is with, is it American Academy of Head and Neck. And so we have come up with our talking points. And then, do you want to show those? Yeah, there's our talking points that we all collaborated on as far as who we are, what we want to accomplish. And you guys can read those. I don't feel like I need to sit here and read those off to you. And then the steps we're going to take. And I want to give a big shout out to Lucy Kennard. She wrote, she wrote an excellent letter to send out. And I wanted to make sure that was shared tonight. So Lucy, thank you. Amazing letter. And so we have, everybody's been assigned contacts to reach out to, and we're contacting them. Email, phone call, whatever way we can contact these organizations and individuals, reaching out to them to see how they can join us in our efforts. Because
the consensus of our group is to, rather than figuring it all out ourselves, we need to reach out to them for statistics, for information, for help, as you said, as Lucy's letter says so well here. You use words, and this is, again, we're trying to build coalitions. Lucy, can we ask you, have you heard anything, any responses yet?
The only response I actually heard was Jill Meyer-Lippert had said she was going to forward my letter to the, the RDH Advisory Board, which I think is another entity on our list, but she was going to forward that. The others I have not heard back from yet.
Here's one of the things I'm going to suggest for you is to make it even more time specific. I would really like to hear, I need to hear from you in a week. Can I call you in a week?
Yeah, I should have done that.
Because even saying it's March of 2020, people think, well, we have a lot of time. We don't have a lot of time. We have very, very little time left to really pull this together.
Lucy?
So,
Yeah.
Lucy,
Go
this is
ahead.
This is
Yeah.
Kathy Forbes. I want to make a suggestion here.
Yep.
Whenever you put in any of your future materials, don't just say CDT code, put CDT procedure code. Put the word procedure on all of that. And I love this letter. I'm curious why you didn't include D0150 has that same wording.
Yeah, yeah.
So, but yeah,
Yeah.
whenever you, because we're trying to get in people's minds, it's a procedure code, just not a code. So from this, for all the groups, when you're, anything you write, just put CDT procedure codes.
Okay, great.
That's it.
Thanks, Kathy.
Sure.
Yeah, and we'll learn, and we're going to learn by the responses that we get. But I mean, it's just a matter of putting the time issue in there and then asking permission to follow up with them. That's how we can create a different level of success in my experience. I know that from booking courses, somebody might, ask me for some information about the courses that I get. It's like, attaches my speaking packet. Can I call you so we can have an appointment in a week? Or can we talk? You know what I mean? It's like making it very specific and asking for a reply, asking for a response. Because again, there is not any, I know every single one of you guys on this call, and we're all busy, crazy people. I mean, they're the best volunteers ever. But we have to prioritize. And I mean, I know I have things that it's like, yeah, I'll get there. But if there's a time frame that's attached to it, my behavior is different then. Does that make sense?
Yes.
Yeah, good point. Thank you, Patty.
Yeah. Okay. So, anything else from the oral cancer group? Are you still considering the code specific? Tell me what's under consideration for because when we get them to call us, what are we going to ask of them?
Well, that's something we've talked about, but we haven't really come to a conclusion on that, whether we want it to be a screening code or a risk assessment code. So I'll put that on our agenda for next time. I mean, we've talked about that, but we haven't decided.
Next, Tasha. Are you
I'm here.
Tasha?
Thank you. Yes.
Is.
Can you hear me? Okay.
Yeah. By the way, I put it all on one. I put these on there's 4 slides just for clarity here. Okay. So go ahead and talk about where your group is at.
Okay. So basically, our group has met a couple times, and we just wanted to get consensus on what exactly we thought would be our direction. Our next step is to build the coalitions. I did reach out to Ann Buttrell. Patty, you suggested that. Waiting for her response.
She's been in Australia for the last 2 weeks.
Yes, I think someone shared that with me. So we'll wait and see how she responds to help us with the 4346. But basically, we decided on 3 submissions, and we basically, the reason for this is we saw that there was gaps in the coding. So we had the 1110 and the 1120 that was a preventative procedure, but we were also treating patients in that bucket with gingivitis. So we really just wanted to bring more specifics to each procedure to kind of close the gap between the prophylaxis and the 4346. So on the screen here, you'll see that we did add the word oral in front of prophylaxis. And what we did in our group is we basically looked at the definition of prophylaxis across multiple organizations. And in the medical realm, it takes you to antibiotic prophylaxis. In some of the dental realm, it's very different. So we did add the word oral here to see if that would be something acceptable to them. And then you'll see at the bottom, we put it is intended to preserve oral health because, again, we want this to be as much of a preventative procedure as possible. So is there any questions about kind of where our thought was here or any comments?
The one thing
Cat
that was
just muted.
very, very clear, Kathy, again, just for the edification of everybody here tonight, talk about what happened this year and what they said about a prophylaxis.
Yes, ADHA came up with I was not at ADHA, so House of Delegates, but they came up with a policy defining oral prophylaxis as the super and subgingival removal of biofilm calculus and extensive stains from two structures to preserve health and prevent disease. And our group talked about it, and based on the last couple times at the CMC, we wanted to keep the initial same language so we weren't rocking the boat too much. We wanted to take out control local irritational factors because we don't know what that means. But we like the term to preserve health. We did not want to add and prevent disease because the research does not back that up. We cannot say, we have all sorts of articles that don't say that a prophylaxis prevents disease. So whether ADHA can support this, I don't know, but we were not going to use their definition. So.
Any comments, anyone?
And then,
I put the final action of the House of Delegates for the definition of oral prophylaxis. I put it in the chat. It was a little different from what you read out loud.
Oh.
You read the definition from the House, right?
Right.
Yeah.
PR5. I read from PR5. Was it amended?
It was, yeah. So
it was. I thought I sent this to Tasha. Let me copy it and I'll put it up here so everybody can look at it.
Okay.
We had it's easier for me to say than do, apparently.
I think the one you sent me, Patty, is exactly what is in the chat there.
It is, because it's the one it's the official one. It's the official one that we just pasted in here.
We used that. We just took out to prevent disease because then we thought the research,
what's cut now?
So, I'm sorry.
You cut out there for a minute.
Okay. I said we use the ADHA information you sent us. We just left off the prevent disease wording.
I don't see biofilm. Did you guys didn't add biofilm either?
We didn't because we wanted, based on the politics of the past, we didn't want to rock the boat too much. And we thought because this has come up and they've not wanted to change the prophylaxis, this group could certainly decide to add that. We were just trying to keep it simple. But I like
Kathy, what was the specific that was said in the letter to you? That's what I want to try and get out here for everybody to know.
The letter to me, I'm sorry. What? When
we rejected our submissions for this year, specifically in the letter, it was written that they don't want to, they didn't say rock the boat, but basically this is a well-defined already procedure that's well understood by the industry, and they don't want to change it. Right. So that was part of the discussion I know that we've talked about before, is changing it as little as possible.
Exactly. I don't have it in here. Nah. Yeah.
It was disruptive. Is what they said. It was disruptive.
And that's, I can't put my hands on it right now. I'm so sorry.
Patty, are you talking about the justification as to why they did not adopt what the group proposed?
Yes.
Correct.
So I know, I believe there are some other delegates in this group. So if anybody can help us remember correctly, but from what I understand, ADHA had formed a task group who had put this definition together because they had something specific that they needed to advocate for in relation to public health, I believe. And so they did not want to change it at all because they had already had plans for it. And then that's when I got up there and started talking about dental implants and how we also have to acknowledge this population. And then so that's how prosthetic got in there.
The reason what I'm talking about is this is from our submissions for last year. So this is what Kathy got as the one that submitted it for our group. And it says rationale for rejecting the change. This was rejected would be disruptive and would be duplicated well understood and established CDT code entity. So I wasn't talking about ADHA, I'm talking about the code committee. That's why, Kathy, what you and Tasha were saying is we tried to keep this as close to what was, but to make it be more accurate for where today is. Is that what we're saying?
That's what we were saying,
Yes.
Okay. Okay. All right. All right. So there we go. So talk about this one, and I did this 2 ways, Tasha. I did it this way with all the cross-outs and out that, okay? Because it gets to be a little confusing.
Okay.
So why don't you
Okay.
explain what you're trying to do, and then we can look at it the other way too.
Yes. So we talked about the 4346 being more the gingival inflammation code and not being so specific to the generalized moderate to or severe. And the reason for that is, again, there was a gap between the prophy and this code. So if the prophy is intended to be preventative, but you have someone with localized gingivitis or generalized mild gingival inflammation, there was a gap in coding there. So we tried to just eliminate the generalized moderate or severe and just leave it as scaling in the presence of gingival inflammation. So you'll see here that we've kind of crossed out some things. We left it to where it's just in the presence of gingival inflammation and the absence of periodontitis. And then we took out the limiting sentence at the end where it does not need to be recorded in conjunction with, or it shouldn't be recorded in conjunction with the prophylaxis scaling and root planing. That's not really on any other code, so we just thought it was kind of limiting, but also not necessary.
So this is your submission, what you'd like it to say.
Yes.
Yes.
One of the things that we thought when we're presenting testimony on this is in part of our thought process, by leaving prophy pretty much the way they've left it, if there's any questioning about, no, we want to leave it at moderate, we could say, well, your prophy code does not talk about what happens to slight to moderate. So this way we are giving them an out because there's nothing about inflammation in the prophy codes. So I say, okay, what do we do with slight to moderate? And we'll see what they would say.
Hi, this is Eileen. I'm wondering though, Siobhan brought up a very good point about prosthetic prosthesis, and I'm wondering if maybe we should add it in here as well, because this is the one that we're trying to change a little bit, and the prosthetic might have some inflammation and all that, and that might stay a little bit more in line with the ADHA. I wouldn't change the prophy code, but does anybody think or have an opinion on if this might be a good place to add it?
I think it makes sense to add it. However, I think that your prophy code and your 4346 should be somewhere in line. And again, the rationale is, baby steps. You don't want to throw too much at one time.
Yeah, we talked about that a little bit, and definitely, we just want to take a baby step this year, and then if they go yes, then we can mend it next year too.
Right. I was just thinking because of the ADHA, just to kind of be in line with that a little bit. But I understand what we wanted, so that's why I just tossed it out. Just thinking.
Okay, good. Thank you.
And where are you guys with the coalition partners?
Well, that's a good point, Eileen. If ADHA adopted policy with prosthetic, I mean, this is the population. This is the reality of it. Dental implants are the standard of care. And so maybe not this time, but most certainly it should be added.
Definitely coming back next year.
I want to add.
That's the intent for next year, but trying to get at least this one passed, I think would be a step in the right direction, and then we can start to add from there.
Well, this is Melissa speaking. As I'm listening to all of this and Eileen bringing up this point and what Siobhan was saying about ADHA, And here we're over in the other group trying to make similar codes for dental implants. Maybe it's a smart way to tag team with Tasha's group and try to bring this a little bit more cohesive together. Patty, what do you think?
I want to hear what everybody else thinks. What do you think? What about Kathy and Tasha from your committee, from the work you guys have been doing? So adding
this is Jill. This is Jill. I think that's an excellent idea.
Because we're ultimately trying to obtain the same goal, right? We're trying to improve the verbiage of what we're doing. We're trying to make it less limited. But, you know, we have the same goal in the implant group to have coding that's going to pertain to that patient population. I mean, I really, because I have 1,000,001 patients that have a whole complement of natural teeth with maybe 1 or 2 implants. Then I have patients who are completely edentulous and fully restored with implant superstructures. So that patient maybe not so much would fall into this category. That would be a separate implant code. But is there a way that we can bridge that gap? Because we are absolutely missing codes in the implant arena for our patients who, like, we coined them, and we, in our coding language last year in our proposals, we called them mixed dentition patients because they had a mixed dentition of natural teeth and dental implants. So is there a way that we can tag team this together? Is kind of where my brain is going.
I get that.
So
I'm afraid
this is Tasha. Oh, go ahead, Dr. Joy.
I was going to say we talked about that in depth, to be quite honest. But the fear is, based on what they said with the traditional Prophy code, is that they just don't like a whole lot of change.
Right. And
Right,
that's,
but we're not changing the Prophy code, we're changing the descriptor.
No. But what I'm saying is that if you keep it in line with what they're saying with the Prophy code, I just not this year. I'm not opposed to it, but I just don't think this year.
But even for the 4346, Dr. Joy, because we're leaving the Prophy alone, that's kind of what we're giving them. But then for the 4346, we're changing it a little bit more. And then if it goes in line with what the ADHA says and what our implant group is trying to say, I don't know. I'm kind of torn. I get both sides.
I remember I was there for ADHA, and there was a lot of back and forth there too. That wasn't a definition that they were able to come up with in just 5 minutes.
yeah.
So,
but
it
was adopted. We're talking about adding 2 words and prosthetic. We're talking about adding 2 words here. I mean, it's another opportunity to just do what it is that's happening in the reality in private practice.
I get what you're saying. It is just 2 words, but those 2 words, I mean, you were there, Siobhan. That wasn't a 5-minute conversation. So,
and if I can add, this is not a little editing. This is a huge change. This is not a little change to what we're offering. I agree. I'm torn because having been there and listened to them, it's kind of like you had to have been there to realize they just don't want to move on anything. And so this is a big deal. The group will ultimately make that decision on if you wanted to add in prosthetic surfaces. But we need to define what that is, because those dentists will not know what that is. Is that crowns? Is it bridges? Is it implants? Is it a partial denture?
But Kathy, do we have to define it?
This
I don't know.
Can I say something?
Sure.
The way you're wanting to change the wording of this code, if I were billing or if I were working, I would use this code if I had an implant that had inflammation around it.
Sure.
Well, there's a code for that already, separate from this 4346 code, but you can only treat 1 tooth at a time.
Correct. But if I had a mass of inflammation, I mean, the thing is, anytime you're going to reword a code or anything, there's always confusion for about 2 or 3 years. It takes a long time before people are comfortable using them. Baby steps, my opinion, baby steps are better. You get further with baby steps. Just my opinion.
Who was that? Who said baby steps?
That was Karen Kamisi.
Thank you, Karen. Karen, I think the only thing is that I don't think it takes 5 to 10 years to get changes understood by so many. Because the unfortunate things, here's the other thing too, that let's be realistic here, guys. When it comes down to it, most practitioners, all they ever see is the number and the name.
That's true.
So even if we put and surfaces down there, most practitioners will not see that. Why? Because most practitioners know what they know about coding from what they see in their computer systems. In their computer systems, it only has the number and the name.
So it's not the practitioner we're trying to convince, though. It's the dentist who are responsible for approving this code or not. That we get it, the practitioners always get it. It's just this unfortunate game that we have to play with the dentist, and that's the frustrating thing about it.
Other opinions, other thoughts?
I'm just kind of looking at it like what I'm learning from the first time around to this time is that less is definitely more. And like with biofilm management, the thing I forgot what I was going to say earlier was that we are trying out, what Jill and I had discussed just on Friday was that we're not going to limit it to using just something like airflow and erythrophil powder. We're going to keep it very vague so that biofilm management can also be done with the laser per se with this coating that we're going to try to propose. So that's the plan on what we're working for. So I'm thinking that this could be similar with the use of the term prosthetic. If we just put prosthetic in there, it encompasses so many different things so that we're not limiting ourselves.
Okay. Well, again, each group, remember, we're all going to vote on these things later about what we're going to agree on. The other thing is this is where coalitions are so important because we need other perspectives. Because how is this seen by other people and other groups? And particularly, again, going back to who else is on this code committee that would help us with this and be in favor of this. And I know we tried to get a hold of Ann Petrell and we didn't. And the purpose of that, for those anybody else, is just because Ann Petrell sat on the original work group ad hoc committee to create this code. I have a feeling all of this was discussed, but we aren't privy to any of that at this point. So moving forward, we're going to submit them, and there is also the thing of that there's sometimes you submit something the way with more than you want it, and then there's negotiation. It's like, well, we can take that out. Lots of different ways that we can play this.
So if I'm hearing what several of you are saying, if we just include between tooth and surfaces, put tooth and prosthetic surfaces, would that work?
That's what I'm thinking.
Because that would include several types of prosthetics, including implants.
Right. Implants, bridge work, single crowns, it kind of like anything that's wasn't put there, people weren't born with it.
Didn't go there.
Exactly.
Anything that's a prosthetic, and that's
that seems like that's
what the discussion was about at ADHA.
Yeah, this seems like a fairly elegant solution to the problem. And what I'd like to do, this is Linda, what I'd like to do is read to you D6101, because I don't know who mentioned it, but they said, oh, there's a code for single implant debridement. I'll read it to you. And what's interesting about this 6101 is there's no descriptor. It's only nomenclature, but it's a long one. The debridement of peri-implant defect or defects surrounding a single implant, and surface cleaning of the exposed implant surfaces, including flap entry and closure. So this sounds like it's, you know, it could easily be described as a surgical procedure that that would need to be done in order to completely debride like an implant. And I think what we're talking about is we want the prophylaxis code to include not quite this drastic a procedure, well, certainly not that drastic, but it has value when it says that it's a tooth that we're cleaning. That's true when it's a tooth, but sometimes it's actually an implant. So I like the idea of trying once again to say what you're asking us to do, both with 4346 and 1110, is we're doing scaling procedures on teeth, is what it says. But in reality, in real life, we're scaling on teeth and implants and other, you know, prostheses.
And other prosthetics. I mean, if we really get down to it, on other prosthetics too.
Right.
Absolutely. And Linda, we tried last year to amend that D6081 code, and we actually approached it in the way that let's make it, because of the flap entry and all that severity of that coding, it does sound like it's more of a surgical than a non-surgical approach.
Well, it could be anything from a very simple scaling all the way up to flap and
right.
closure. So yeah.
Right. But we decided that let's try to amend that, and we tailored it after the scaling root planing coding, and we did 1 to 3, and we just basically mimicked that, but made it for implant dentistry, and that also did not go through.
I know. Well, you know, we'll tackle
right, but it's the first time in the 10 years that I've attended the meeting that anything like that came through at all.
Yeah.
And again, we have to go back to the politics that was going on at that meeting. There's lots of pieces and parts, and let's not overcorrect based on what happened this year.
Mm-hmm.
And that's one of the things, you know, we don't want to go from one side all the way over the other side. What is the, you know, so let's keep that under consideration, but let's move on to the next group. Again, coalitions, because when we can get other people's opinions, we get a better thing in the long run. So thank you. And Linda, you're up because this is, again, what you came up with, but give them a little background again on how this came about, what we did this year, and where we're at now with this, with what you've written up.
Sure. Okay. First of all, my name is spelled with S-O-N, not E-N, but, you know, maybe that makes me harder to find.
How the heck did I do that, Linda? I know that.
It's been S-E-N the last couple of times, and I haven't bothered to mention it.
Okay, fine. Well, then you better change it.
All right. Okay. So when it says on this slide, it says DXXX, there should be 4 X's actually. It means that this is a brand new code. And the reason it's a brand new code is we tried last year, a little history, we tried to incorporate vaping. Vaping was the big issue. We knew that we were going to start seeing, and we already have been seeing problems with you know, oral manifestations of a problem resulting from vaping and e-cigarettes. And that we might have to counsel patients about that. We want to be able to counsel patients like that. And then try to incorporate it into the tobacco cessation counseling code. And that's where the CMC said no. It was like absolutely not. We can't. That's all about the tobacco settlement. That code is there, and the counseling is there because as a result of tobacco settlement. And to me, that meant they wanted, and they could see, there wasn't real opposition to having something about vaping and counseling and advising patients who are using e-cigarettes and vaporizers. It wasn't about that. It was just that we couldn't do anything to the tobacco code. So then when we started talking about, well, what are we really talking about? Shouldn't we talk about all the other things? And so down in the descriptor below, we have alcohol, opioids, nicotine, cannabis, methamphetamine, and other pharmaceuticals and chemicals. And it's not just, but we had nicotine in there because that's the first thing we think of in a vaping device or an e-cig. But as we're finding out, people are putting everything into those vaping devices and vaporizing it. And so we thought we didn't want to stick with vaping because the other substances were causing trouble too. We were pretty sure. Anyway, so here's what we came up: counseling for the control and prevention of adverse health effects associated with high-risk substance use. We didn't want to talk about abuse. We didn't want to talk about addiction. We didn't want to add to the stigma in this code. We didn't want to build in anything like that, but just this is a recognition that substances come with risks. Some are higher risk than others. Some are low risk, but they can be used, I mean, on the face of it, they can be used in high-risk ways and cause trouble. So that's what we came up with. I think this is good. Oh, another thing that's in the tobacco cessation counseling code that we did not include here, it said in that code, it says adverse oral health effects associated with tobacco use. And we thought, you know what, that, at least for me, it's sort of like stay in your lane, only talk about the oral effects and don't talk about the lungs and heart disease and all the other things that can come with tobacco use. So we decided that there was pretty good evidence of especially lung disease with these vaping devices, and we wanted to just recognize that we don't want to limit this code to just counseling about adverse oral health effects.
And there's been the first death, so that'll add to your
Illinois. Yep.
In Illinois, yeah.
So anyway, we really, I don't know. Okay, so then we talked about what we could do to connect with, especially the AAPHD and Sharon Perlman. Dr. Perlman is the representative on the CMC, the Code Maintenance Committee, who really, really wants, she's from the AAPHD, she represents that organization on the committee. She really wants this code, and she said in an email message to me that she is determined, I think that was the word she used, determined to see a code for vaping. But again, when we started sort of processing it all, we had these other devices, other routes of administration, and then also substances that we thought this code should cover. So anyway, our strategy for connecting with the AAPHD and Sharon Perlman, she's open to it. Sharon Perlman is open to it, but we thought that we would connect with Ann Petrell again by waiting for her to get back in her office after being in Australia for a while. So that's our. What do you think of? What does anybody else think of this?
Well, John here. I in light again when this was discussed last year, many of the evidence-based information regarding the severity and the challenge and the dangerous aspect that vaping brings was not as apparent as it is now. And with the series that we've done on CNBC regarding the vaping industry and the targeting of children, et cetera, and so forth, and the dangers of using the vaping instrumentation, which have exploded over the course of the last year, I think there's more and more of a concern regarding it. And you may have a better opportunity this year to move the needle. So don't give up on this.
Sharon was really, I mean, actually, I went back to my notes from the meeting this year, and Sharon in public health was absolutely, this has to pass this year. I mean, she almost shouted it for those of us that were there.
Yes.
And they really tried to wordsmith this on the fly at the committee. And that's where I think, Linda, from my opinion, looking at this, I think you guys have done a great job.
Absolutely.
Bringing this forward. Val, Val, go ahead and share what you said in the chat box, because I think it really reinforces what John just said too.
Yeah, so I was just actually at dinner with my one of my former dentists in Arizona last night, and he had shared with me that he heard, now again, this is hearsay, but that there was just the first reported death linked to vaping. It was a 30-ish-year-old who had COPD that died. I want to say it was in Michigan or somewhere of that nature. I have to look it up, but he had shared that with me. And of course, what we have with the whole opioid crisis.
Illinois. Yeah.
Oh, Illinois. Okay. Okay. Yep. So that was, yeah. And he's from Illinois. That makes sense. And then, you know, the opioid crisis, just like Dr. John, you just said now, you know, I think, you know, it's something I think it's absolutely necessary because this is where we are in the world today. It's relevant. And you know, with the crisis we have with opioids and other vaping, it's certainly something that we are faced with every day as clinicians.
Yeah, and I think that you have a greater opportunity this year to actually move this forward, and a wonderful opportunity to help our patients and our profession as we try to curtail this scourge as well. So I commend you all for moving this forward.
What about AGD, about getting AGD on this? Do you think we could get them to join with us? I mean, you know the AGD politics.
Well, again, it's changed since I've been Speaker of the House, so I can't really answer that. I know that the AGD Foundation is very oral cancer focused. Certainly they're anti-tobacco. I would almost wager they would be anti-vaping. Jerry Botko in Florida is the chair, is very much involved with that. So he would be somebody that maybe we can connect to the group and see what they think about helping. Again, there's always politics involved, and the AGD would probably defray some of the thought process to the ADA, but the ADA and AGD have been in lockstep with a lot of things regarding oral health and tobacco. So I would almost think that there would be, and again, in Chad Doheny, as he comes into his time as president the next week or so, as Jeff Cole steps down. Again, I think we have an advocate for oral health in that capacity too. I know Chad very well. He's a terrific guy. He and his wife, Rella Rekka, have been good friends of ours for a number of years.
And Linda, then can you reach out to John and you connect you and Jamie with John to get those connections so that we can follow through on that?
And does anybody have any idea? We looked up the little work group looked up a position paper from the Academy of Pediatric Dentistry, and they do have a position paper on e-cigarettes, you know, with some obvious comments about not marketing to children and blah blah blah. But it was written probably 6 years ago, and all this data and these cases are coming up now. So that was well before the wave started of illnesses and now a death. So yeah, I was going to say something.
So, and
else.
then also Kathy, don't you have the contact from AAPD from last year?
Yes, I do.
Okay, so that Kathy has that contact. And then Susan, if you also, if the AGD Foundation is really on the oral cancer part, smoking and all that kind of stuff, maybe that's also another good contact for our oral cancer group.
Right. So basically you can reach out to Karen or myself, so we have those connections for you because we know.
Yeah, terrific.
Great. Thank you, John.
I remember what I was going to say, Patty. It was in our justification for having this new code, we're going to start with the call to actions, the calls to action that have been issued by federal agencies and governmental officials and public health officials. There's it's like it's getting louder and more insistent. We have to do something, and this is
even with you can use ADA has their own position paper and whole system for opioid abuse and what's going on with that. They passed that last year.
Exactly.
So use ADA's own stuff with it.
Does ADHA have any policy about vaping?
Ooh, you know, I don't think we do.
No.
So there we go. Something
This is
we need to
Jill.
have.
No, not to my knowledge.
Yeah.
No,
All right.
not to my knowledge. They have anything on vaping.
All right. Yep. I think, yeah.
There's policy for next year.
Good point.
Okay, so what are you going to do next is really going to depend on what group you're at. I think each group is in a different place. I think obviously the coalition is building is really important with all of those, because again, the more we can get other people to sign on with us, that's where we're going to have success. But the timeline now is really tight, because in order to have those coalitions and all of our insiders be able to vote on these things, we've got to have this stuff done by 1 month from right now. It needs to be that way. Now, let me give you again. So this is the ones that I was talking about before. As you can see, this was brought forward by the Academy of Periodontology at NADP. Now, this time it didn't pass, but more often than not, when there are more than one organization, and these are both voting members of that committee. That's the other part too. Is you want to look at as many coalitions as we can. But the voting members, you get somebody already that's voting on our side, that does help, and they can influence other people in the political end. We don't get to go in those meetings that they have. We don't get invited to their breakfast and their lunch and all those other times when they're talking between themselves. So having a voting member support us is something that's really important too. Now, here's what I'm going to do. Kathy did so much work. She really took all of this on, and we're not going to have it happen this year. Because she can't. I mean, it's ridiculous. So I'm going to do some fishing, and this is particularly the chairs. I mean, the leader of each committee as well as the mentor. We're not going to hand feed you what the form is. We're going to teach you where to go to get it. So this is, again, remember, you just go ADA, CDT, and it clicks you right over here. And it's the request to change. So now I'm going to go live. And over here is, and again, you can look at this in your own order, but this is the instructions for completing the forms. All of this information is there. Submission of the guidelines, that's all there. The actual form you need to use, those are very specific. It's right there. Just download it. I'll download it and show you that it is a simple Word fill field document, okay? You just type it right in those spaces. That's what it's designed.
And you'll be using my name and address, so you can just leave that stuff blank until
we'll get to that, yeah.
I will tell you. Go ahead.
Hold on, let me just show them first, Kathy. Okay. What's important for you to understand, though, is particularly this part, transmitting your code action. You're not going to do that yet. But you need to think ahead and look at all of these things in order to make sure that you've got it right. Unprotected Microsoft format, et cetera, et cetera. Read through and evaluate all of this. Now, this is not the job of the chair of the committee either, or is it the job of the mentor of each work group? It's the job of the entire work group, okay? It's too much for a single person, and it certainly is too much for a single person to do it for our whole group. We don't know how many we're going to ultimately have, but we do need to start getting them into that format of the way they need to be. Go ahead, Kathy.
One of the things that can be confusing, where it says right there, oops, copyright assignment. Can you go back to that page?
Oh, yeah, you can go back to copyright.
That copyright, where does it say?
There it is.
If you are going to submit the intent is if you were going to submit an article, you have to get the publisher's okay, and there's a whole bunch of stuff you have to do. All we've done in the past is we've referenced the bibliography, and that allows the reader to go to it if they want to, so that you folks don't have to go, okay, we have to call RDH Magazine and get the permission of the editor and the publisher, and don't have to go through all that kind of stuff. So this wasn't exactly what I was looking for, but the idea that when you start reading through, it'll talk about getting permission to publish an article. You're not going to do that. You're going to make out a bibliography, a formatting like you would do to reference it.
So let me just go to what I did put in. Let me go back. I'll do this in the order that I put it in here. What I did do is in our Dropbox that we're sharing for these work groups. Right here, it's called the DCC submissions for our committee. Kathy's created the pattern for us. You don't have to reinvent the wheel either. So in there, what we have is these are the ones that we had from last year. So this can be the same. Now, if we would like this to be something else, then, you know, that'd be great if we had more than the Dental Codology Consortium. But you can see this is what she was talking about. There's the literature review. There's 9 articles. She's referred to those things here. We've got a real lot of information, but this is what she's talking about, okay? All of you have access to this. And if that one doesn't quite, you know, get you everything you need, then we have other ones in here. We put all of our, it's 58 pages. That's why I didn't send it to you in a handout. Again, it's in our Dropbox under DCC only submissions. This is in our Dropbox for the work groups. Any questions on that so far? Okay.
And I will say that you know, I would be happy to, if you
shut up, Kathy, not yet.
Not yet, all right. I'll be quiet. I'm going to mute myself.
I'm going to control your girlfriend.
I'm going to mute myself.
We're teaching people to fish here, okay? Also, on the instructions, do not hesitate to pick up the phone, call ADA, or contact them via email. It's great. People, the committee knows me. They know Kathy. But boy, you know, part of what we're trying to do, and let's not forget one of our goals, is to get a hygienist and other professionals, including assistants, Karen, and office managers on that code committee. And the more of us that we show interest in this and participate in the process, the better off we're going to be in the long run, because we're really showing, again, going back to something John was talking about earlier, the idea of a team. All of us on a team working together, we're going to get better outcomes. Now, do we absolutely have the best ace in the hole there could possibly be with having Kathy? Yes. Okay, Kathy, go ahead and volunteer. Kathy's there to help, right? Kathy?
Excuse me, I muted myself to keep from,
okay,
kind of like putting duct tape on me. No, I will be happy to help and answer questions. Just email me.
There you go. There you go. Thank you. Thank you. So again, our next meeting is on Sunday the 29th. The submissions need to be completed. What you can do is notify me when you put your submissions in the Dropbox. Each of you have a Dropbox. It needs to be on that format. Just text me or email me when you have it in there, okay? I'm not going to vote on them. I mean, I'm not going to fix them. I'm not going to do anything to them. We're going to bring them to the committee, okay? Any questions? Tasha, you good with that?
Yes.
Susan?
I'm good.
Yes.
Okay. Patty?
Yes.
Got it. Melissa?
All good, Patty.
All right. Linda, for Jamie?
I have a question. Of course, yes, but do you want us to start working on the justification, the rationale?
We have to.
Yes.
We have to.
Gotcha.
We have no choice at this part. This is where, again, the timeline comes in. We've got to work on the whole thing, because, again, if you're looking at the form, let me go back to that form so we can see it. Here's the form. That's just the first part, but here's all the justification. Here is this is the entire form that needs to be filled out on each individual submission. Okay?
Yes, ma'am.
Got it? Okay. And again, they go in the Dropbox. Now, let me give you a little bit of an update also on the next code committee is, we've said this a few times, March 12th and 13th. One of the key things also, it's not just to build the coalitions, is if you have people that you're in contact with that also would like to testify to support our positions, that's extremely helpful. And if you want to be there yourself, it's extremely helpful. We know that that's something that takes a lot of commitment because it's a 2-day meeting, although usually you've been doing it 1 day, and you have to take off work, et cetera, et cetera. So we've been working with, and we've had our third meeting now with ADHA to work on getting scholarships to fund people to come. I don't know that we're going to be able to bring it together for 2020. Kathy, what's the words? How do we end up saying that when we're on the call?
I don't know. I'm not sure what you're asking.
What we did, remember we said we're working on.
Yeah, it probably is not going to happen for this year for sure, because we've got to get ducks in a row. That we it's kind of like we would love to say sure, but we don't have the pieces in a row, and then when it happens, then when the time comes and we can't deliver, then it just makes it look even worse. So we'd rather have everything else lined up before we make that commitment.
Good. Because one of the things that we realized is that in order for you to really plan for it, in order to find out if you get a scholarship or not, that we would need to let you know by December 1st. Because just for planning, now we know, you got schedules, you have this, you have that. So it would basically be we put our submissions in on November 1st to the ADA, and that's the 1st of November. By December 1st, we would be then announcing the scholarships. But we just don't see that timeline is going to be able to probably work out, because this has got to be done. This is money, this is legal, it's got to be done in a very specific way that we just haven't got the time to do this year. So anyway, this is, you guys,
Patty,
go ahead, anybody else?
Patty, yes, Patty, I have a quick question. On
Sure.
the dates for March,
yep.
Is it, when exactly do they go before, do public go before the commission? Is it on the 15th? Is that when the proceedings begin? That would be the most important date for somebody to show up?
No, the most important date for somebody to show up is the 12th.
Early.
The meeting will start at 8:30 on Thursday the 12th at ADA headquarters.
8:30.
What does it mean? Well, what does it mean by proceedings start the 15th at 8:30?
It says 12th. Proceedings begin on March 12th at 8:30 for ADA. Okay.
Jill, you might be looking at last year.
Yeah,
Okay.
look at what's on the screen now, Jill. That's the current one. Okay. That's the current one.
Proceedings begin on March 12th. Oh, okay.
Got it?
Okay.
All right.
Got it.
Any other questions? Any other clarifications? Thank you, everyone. This has been a fantastic meeting. I appreciate all the opinions, all the ideas, all of the brainstorming, and this being also a safe place for all of us to share what we think, what we feel, and help us to move our profession forward, because face it, that's what it's all about. There's no doubt that every single person here is dedicated to patients and doing the very best for our patients, and then having the system that supports us doing the best for our patients. That's the recipe for success. That's what we're all working toward. So hooray for the work groups. You guys are doing, again, if we had to do every single one of these meetings and every single one of these things together, yeah, it'd be really hard. You know how to get me? Text me, email me. Another date to put on your calendar is on September 11th. Related to that code that we were just talking about is we have Sandra Berger's going to do a mastermind on cannabis, weed, CBD oil, and others, so we can talk about that. Again, that is on September 11th at 7 p.m. Central. And I think that gives us the date. Thank you, everybody. You guys are doing an amazing job. And I wish you all a very good night.
Night.
Good night.
Night.
Night.